Hello, welcome from the Orthopedic Division, Canadian Physiotherapy Association, as well as from myself, Lori Maffey, to the lecture entitled Detection, Prevention, and Management of Groin and Hamstrings Injury in Sport. There was a variety of different forms of evidence that was used in the composition of this lecture. There was experimental evidence that was used, randomized control trials, observational evidence, cohort studies, case control studies, cross-sectional studies, case theories, and case reports, as well as expert opinion. In order to interpret the evidence, critical judgment was used. This consisted of consistency of independent investigations, looking at the strength of association, i.e. the dose response, looking at the specificity of association, looking at the temporal relationship, as well as the coherence, the biological. We'll look at groin strain first. Groin strain injury is the top 1 to 6th most common cited injury in sports of hockey, soccer, rugby, also called Australian rules football in this study, calisthenics, and cricket. Sport-specific groin strain injury rates vary in the literature from 0.2 to 5.17 injuries per 1,000 participation hours. Sport risk factors for this particular lecture are defined as any factor that may increase the potential for groin strain injury. Groin strain injury was defined as abdominal muscular injury, hip flexor injury, hip adductor injury, as well as abdominal and inguinal hernias. So who gets groin strains? Well, they're associated with sports involving rapid acceleration or deceleration, cutting, jumping, or turning. The clinical presentation of somebody with a groin strain is a sudden onset of medial and/or anterior upper thigh, associated with localized tenderness and loss of function, maybe localized swelling and tenderness, may not be any ecchymosis or bruising, and it's unusual to have a palpable defect. There may be insidious onset with poor localization of. Chronic injuries describe a feeling of tightness or impending pull, a lack of coordination and strength on weight-bearing, often associated with pain and decreased ability to do explosive speed activities in both new and injuries. There's pain on resisted hip flexion or abduction when supine with decreased strength. Variant tests have been described in the literature as good tests to use to see if there might be a groin strain injury. This is the squeeze test, hips at 45 degrees, of knee flexion and hip flexion, and doing a resisted movement to cause pain. Bilateral adduction test, hips at 30 degrees with knees straight, slight abduction and slight internal rotation, and then do a resisted testing, causing pain. And single adductor test, bringing the hip into the position that's shown on the photo, and then doing a resistance against that, bringing on pain. It should be noted that often does not have to be maximum resistance to bring on pain. It's often just a slight amount of resistance and pain comes on. So I personally suggest that you do a slow graduation of bringing on resistance, or suggest that to your. There's also a reduction of active straight leg raise. No, this is often on the. So the results of a systematic survey that I did on groin strain injuries and risk factors associated with them, that was published in 2007, looked at 175 potential studies, of which 11 studies met the study criteria and were identified for the use of the study. They were in the sports of soccer, rugby, Australian rules football, hockey, and swimming. There were cohort studies, interventional studies, cross-sectional studies, and case. The risk factors that were identified in the systematic review were as following. There was no evidence or conflicting evidence for the use of adductor strength, peak isometric adductor strength, for a risk factor in groin strains. There was no evidence or conflicting evidence for hip abduction range of motion being a risk factor for groin strains. There was varying to little evidence for age and experience as a risk factor for groin strain. abductor strength, there was a little bit of evidence for that. The non-dominant limb peak torque predictive and peak torque later in the abduction range of motion in isokinetic testing was slightly predictive for a risk factor in groin strain. Sport specificity training, there was risk factors for that. There was consistent evidence for risk factors for groin strain injury if the person had a previous injury of any sort in the lower quadrant or torso area. AB or AD, the AB to adductor strength ratio of less than 80% was predictive for groin strain injuries, or was a risk factor for groin strain injuries. Core control, if there was decreased core control in 2 interventional studies, it pointed towards being a risk factor. And decreased levels of preseason sport-specific training were also shown to be strain injury. So if we look at these in terms of other consistencies in the literature for each of these factors, let's look at previous injury first. There's a rationalization for post-injury rehabilitation for specific exercises to prevent injury occurrence. This is not rocket science for any purpose out there. The investigations in the lumbar spine show immediate post-injury. There's a multifidus atrophy and contraction, onset delayed of transverse abdominis, and most of you in the audience are familiar with these. Additional studies highlight that post-injury focused muscle training to improve functional status and minimize injury occurrence occurs in these multifidus muscles. This shows consistency of previous injury may potentially be a risk factor for groin strain injuries, as well as consistency in the evidence out there of other muscles showing such an issue. Results of modifiable risk factors are adductor strength. There's no evidence that peak isometric adductor strength is a risk factor. There is slight evidence to show that there might be a prediction for a risk factor, as I said earlier, in non-dominant limb peak torque predictive, as well as peak torque later in the abductive range of motion in isokinetic testing as groin strain injuries. Other modifiable risk factors, interventional studies this time, we're looking at adductor to abductor ratios. Tyler, in 2 investigations, found, as I had stated earlier, that adductor muscle strength by concentric, eccentric, and functional exercise programs for those with adductor to abductor muscle strength ratios of less than 80% were effective in reducing groin strain injuries. Consistencies for this particular information regarding muscle strength. A systematic review examining muscle strength as a risk factor for acute injuries, done by Emery, showed that a majority of studies based on hamstrings injuries in elite athletes. Most studies demonstrated previous injury decreased hamstring strength and or hamstring quadriceps ratio to be predictive of hamstring strain injury. And there were similar concerns regarding internal validity for all the studies looked at. Consistency of abductor to adductor strength ratios. Well, it's hypothesized that ice hockey groin strain injuries caused by eccentric force of adductors attempting to decelerate the leg during stride. Clinical observation. Systematic reviews, as I just stated earlier, showed that decreased muscle strength or muscle strength ratios may be predictive of strain injuries. Systematic reviews on muscle stretching. Most muscle injuries occur during eccentric contractions within the normal range. Studies examining recreational runner injuries, significant muscle imbalances in the abductor and hip flexor group between the injured and uninjured side. And a study involving collegiate athletes showed a significant decrease in ratio of hip abduction to extension strength in injured athletes. So the thinking point from this, from both the systematic review that I did regarding groin strain injuries, as well as consistency in the evidence out there for other related factors for muscle strain injuries, may be that adductor strength, be it concentric or eccentric, throughout its length may be important for injury prevention. Looking further at adductors as intrinsic and extrinsic stabilizers, the adductor's muscle's capacity to influence the pelvis, sacrum, hip, and lower leg is required in order to have a thorough understanding. The functions of the adductors for all these different anatomical regions function simultaneously. There is an increase in demand for dynamic extrinsic adductor function that reduces the muscle's capacity for its stabilizing intrinsic functions and vice versa. Another way to say that is, if the adductors are having to stabilize the pelvis because the other core muscles aren't doing their job, then there is less ability for the adductors to work as adductors for the hip in either an concentric or eccentric fashion, and therefore overload may occur, creating injury. This schematic diagram talks about this. Weak posterior lumbar segmental muscles cause an overuse of tight superficial erector spinae muscles, which may cause further overuse of adductor muscles as they try to stabilize and assist the abdominal musculature. Looking at it this time from the multifidus muscle as opposed to the abdominal muscle example I had given earlier. Continuing to look at results of the systematic review that I did, modifiable risk factors, the Australian rules football players with long-standing groin pain versus controlled showed evidence of onset of transverse abdominis muscle recruitment activity delayed with no other differences in the other abdominals. Interventional studies looking at rugby showed Swiss ball core stability intervention targeting abdominals and gluteals resulted in fewer injuries in the intervention group, but that particular study lacked power based on subject matter of 39, so there weren't statistically significant results shown on that, only a trend. What other consistency is there in the literature with regards to core stability as a decrease for risk for muscle injury? Well, there's a thought that there's an inability to load transfer from the legs to pelvis and torso, and restoring load transferability by restoration of stabilizing muscles of the pelvis by belt or abdominal contraction may be important in injury management. And studies examining peripartum pelvic pain and low back pain suggest that stabilizing the pelvis by training the transverse abdominal muscles or by belting may improve the load transferability and therefore decrease. In a study by Best and Sherry, 7.7% versus 70% of hamstring strain reoccurrence was shown. What they did in that particular study, which we'll talk about later in the hamstring section, was within 2 weeks and at 1 year, it was shown that athletes that performed progressive agility and trunk stabilizing exercises had a 7.7% reoccurrence of hamstrings injuries. This was compared to a group that performed static stretching, isolated progressive hamstrings resisted exercises, and icing. They had a 70% reoccurrence of hamstrings injuries. Strength imbalances have been talked about in the literature with regards to propulsive muscles and hip and pelvis stabilizing muscles. And imbalances between all these propulsive muscles and these stabilizing muscles has been proposed as a mechanism for adductor strains in athletes. And this proposal has been around since 1987, over 20 years. There is support in the literature with ice hockey athletes, long-standing groin-related pain in these athletes. There was an interventional group performed strength and conditioning exercises for muscles acting on the pelvis, and these athletes fared significantly better with regard to their adductor-related groin pain. Luton showed that lower core stability measures were found in injured versus non-injured athletes in a study looking at risk factors for lower extremity injury in athletes. And almost everybody in the audience is familiar with this particular group of studies, but healthy athletes with a central nervous system, dealing with stabilization of spine and pelvis by contraction of the abdominal and multifidus muscles in anticipation of forces produced by lower limb movement. With injury, maybe there isn't this stabilization. Transverse abdominis and oblique muscles appear to contribute to the function, not related to the direction of lower limb force movements. Again, further support for the use of core and the role of the core in possibly reducing risk in lower extremities, i.e. groin injuries. Now, looking on at other modifiable risk factors that we had talked about earlier, sport specificity of training. The risk for groin injury is greatest in those specializing in breaststroke, greater than individual medley, versus a combination of non-breaststroke and individual medley sports. There's decreased levels of preseason sport-specific training as evidence for modifiable risk factors in groin strain injuries. In hockey, those that did less than 18 preseason training sessions had a relative risk of 3.4 for groin strain injury. Those that did less than 18 sessions of sport-specific training during the regular season had a risk ratio of 2.3 for groin strain injury. So it possibly means that the increase in preseason sport specificity training or sport-specific training and subsequent decrease in groin injury may be supported by eccentric training of thigh muscles and abdominal support musculature during the This preseason training caused further contraction and sport-specific recruitment of these muscles, which might allow for more effective utilization and less onset of fatigue as the season progresses. Fatigue has been noted as a contributing factor for muscle injury. So the thinking points now are perhaps the balance of all dorsal muscles is a critical factor in groin strain injury and reducing its risk. Weak posterior lumbar segmental muscles may lead to overuse and resultant of tight superficial erector spinae muscles, causing further potential overload to the adductor muscles as they try to stabilize and assist anterior torsal muscles, i.e. the abdominals. This can also be taken in reverse, replacing abdominals not being used correctly and the erector spinae becoming overloaded with the adductor. It may be that the adductor strength, i.e. concentric and eccentric, throughout its length with balanced and strong torso may be important for injury prevention. Other modifiable risk factors that were identified in the systematic review that I did, there was some evidence for decreased hip abduction range of motion. It was conflicting evidence. Evidence was shown in soccer and Australian rules football as decreased hip range of motion being predictive of groin injury, but there was no evidence shown in rugby, hockey, or soccer for hip range of motion in the abductors as a modifiable risk factor. There's a lot of debate about flexibility in there. Improving flexibility in the literature has been shown that stretching is the most common piece of injury prevention, enhances sport performance by given by coaches and sport medicine professionals. Yet there's not a lot of support for this. Recent review of stretching found that it was not significantly associated with reduction of total injuries. Debate over flexibility may have to do with inconsistent methods of testing and definition of flexibility. Growing evidence that stretching may be functional to the activity demands of the sport as well as the individual body concerns of the athlete. So thinking points now. It may not be the adductor muscle length that is an important factor for groin injury prevention, but muscle length of its synergistic and opposing muscles as the abductor and hip flexor muscles. Future work in the area of flexibility may shed light on its importance with regard to injury prevention. So future work thinking outside that bubble. Looking at consistency in studies, looking at injury definitions, making them consistent, and looking at valid surveillance methods in these studies, making sure that studies have adequate study size, and looking at critical considerations of possible confounders in the study, such as ice conditions, warm-up and cool-down conditions, etc. Potential factors related to proximal and distal components involving anterior and posterior torso as well as the leg, looking at eccentric isokinetic strength as well as these ratios of adductor to abductor muscles, looking at load transfer and torso stabilizing muscles, looking at muscle length of the adductors as well as its synergistic and opposing muscles such as the abductors and hip flexor muscles. Now, if we pause a bit from the groin strain and look at the hamstring strains and see what evidence is in the literature. There is a variety of different risk factors for hamstrings that is reported in the literature. Age, previous injury, low hamstring strength, low ham squat strength ratios, decreased flexibility, inadequate fatigue, and peak performance ratios. Some of these look very similar to the groin strains risk factors, don't they? In a systematic review, looking at risks for hamstrings injury, Foreman identified that there was limited evidence linking the following as predictive variables: preseason neuromuscular proprioception, age, race, meaning ethnicity, preseason hamstring quadriceps muscle strength, and past history of injury. So although there was limited evidence for those, there was conflicting findings for hamstring strength and previous hamstrings injury in itself. And the conclusion was that there was no single factor that was found to be consistently associated with hamstring strain risk factors. An AFL injury surveillance data study showed that the most common injury in English football and the AFL was hamstring strains. 12 to 16% of the injuries was this. There was no change in 10 years of injury rates for these particular, for hamstrings injury. 15% of athletes missed games or during the season secondary to hamstrings injuries. The average recurrence rate was up to 30% for the remainder of the season once they had a hamstrings injury in that season. Two most common risk factors identified in this surveillance data for hamstring strains were the patient's age and previous injury to the same muscle. Injury mechanisms that have been reported in the literature for hamstring strains using a clinical model: two joint muscle strains during sprinting activities when undergoing eccentric contractions is the reason why hamstrings get strained. Using biomechanical models, prediction of injury is based on joint kinetics and kinematics. Again, looking at a knee and a hip and the fact that this muscle crosses both of those. Animal models, injuries occur at the site of maximum tissue strain, and it's been shown that there's a lot of strain during the hamstrings eccentric loading in the phase of running. Primary intervention studies of hamstring strains Asling looked at 30 elite soccer players on 2 teams, and he divided it into 2 groups. 1 to 2 times a week for 10 weeks they did eccentric training of their hamstrings, and the control group did no treatment for 10 weeks during that time frame. These are people prior to getting a hamstring strain, looking at the soccer players. The lower number of injuries was in the eccentric training group, 3 out of 15, versus the control group, 10 out of 15, over a 10-month period. And it was noted there was no difference in flexibility of passive hip flexion between the groups or between legs on these hamstring strains, or in any of the group, the control group, or primary prevention. Another study looking at hamstring strains, a study in 1999, looking at participants from 1999 to 2002, looking at hamstring strains and the exposure recorded by the team physical therapist at that time. And there were a lot of limitations of this particular study, mainly that it was non-randomized controls, or non-randomized exposures. But it did identify, out of the 20 Icelandic teams during that time frame, in the Norwegian League there were 14 teams all year. The prevention program that was used was flexibility or an eccentric strengthening. Both of the groups did their own stretching as well. So there was just flexibility, or there was flexibility in this Nordic stretch program. And what was found was, in the flexibility training, there was no difference in injuries. In the eccentric training group, there was a 65% overall lower incidence in hamstring strains. The study limitations were well noted by the authors, that it was non-randomized trial, there was actual compliance was not measured within the group, and the clinical diagnosis of injury wasn't nailed down during the study, so there may have been issues there. But overall, it certainly did show a trend, a very significant trend, although not statistically significant maybe, for eccentric strength training. There were similar findings done with rugby in a study done by Brooks in 2000. In secondary prevention of hamstring strains, which means a second injury, there were 3 studies that were looked at. They were RCTs, or randomized comparative trials. And no trial of intervention versus rest was looked at. There's limited evidence, and the conclusion of the Cochrane review was there was limited evidence to suggest that rate of recovery can be increased with an increased daily frequency of hamstring stretching exercises. Consideration should be given to the lumbar spine, sacroiliac, and pelvic alignment and postural control mechanisms when managing hamstrings injuries. Lumbar stability and pelvic motor control may be factors in reducing the rate of reoccurrence in hamstrings injury. Again, Mason's findings in this Cochrane review in 2007 echo what the findings were of my systematic review for groin strain injuries, looking at that postural control and the coordination between that and the groin, and in this particular case, coordination of that in the hamstrings. Revisiting the study by Sherry and Best showed again prevention of reoccurrence of hamstring strains. This is reoccurrence, so somebody who's had a hamstring strain and a reoccurrence of hamstring strain. There was a 70% reoccurrence in those that did not do core stability, as opposed to a 7.7% reoccurrence of strain of hamstrings in those that did do core stability. And what evidence is there in the literature for strength deficits of the hamstrings as a reason for recurrent hamstring strains? 26 athletes of non-acute and hamstring strains, 12 of them being reoccurrent. 18 of them had significant eccentric hamstring strength deficits, or mixed eccentric flexor concentric quadriceps ratio deficits measured by an isokinetic dynamometer. Eccentric training 3 times a week until deficits were within 5% of each other was able to be done for 17 of the 18 subjects. And no reoccurrence in 12 months with return to prior sport occurred in this particular study. So again, it's showing that there may be, again, a strength issue, and it may be strength ratios that are important, and looking at isokinetic testing and eccentric training to reduce reoccurrence of injuries, just like what was found, or a trend that was found in the groin strain. Now this is some interesting work here showing the optimal length for active hamstring tension. The optimal length for peak torque or active tension is shorter or more flexed knee angle in previously injured hamstrings. The unstable decelerating limb will now be in its working range. So what it may be is not so much the overall range of motion that's changed, but the range of motion where the peak torque is generated that's predisposing the muscle to injury here in hamstrings. I found this study quite fascinating. And the explanation for this was shorter contractions during rehabilitation and scar tissue linkage during the muscle fibers recovery led to the importance of advocating eccentric rehabilitation, not just concentric rehabilitation and passive stretching. And this was done, eccentric training done, and it showed that you could restore peak torque after 7 days of training at a longer range of, or a larger range of motion, or towards normal with this sort of training, eccentric training. Other evidence in the literature shows a relative absence of high-quality studies for both prevention and treatment for such a common injury as hamstrings. And it may again reflect that this is an important issue in terms of cost in sport and missing sport time as well as the general population, but it may reflect that there's a complex nature to this, and this is what mechanisms and time of injury are not entirely clear with hamstrings. Does the injury occur in the hamstrings during a change from eccentric to concentric activity? Risk factors, primary versus secondary prevention of hamstring strains may be different. First-time injury to recurrent injuries. Passive stretching may not be effective, and it seems to be what everybody seems to want to be doing out there, and a lot of the studies include this. Maybe this is just confounding the data. And treatment and secondary prevention may be related to functional eccentric strength and an emphasis on lumbar stability and pelvic motion control. And really, this is just starting to creep its way into the studies and in reported literature, although it does seem to be a consistent finding in both groin strain and hamstring injuries and reoccurrence of injuries prevention, looking at this lumbar stability, pelvic control motion, and eccentric strengthening of the involved muscle. So all that's well and fine with your groin strain and hamstrings patients, but what do you do right now? Well, rehabilitation keys, not new to any of you, is establish a complete and accurate diagnosis. Look at the phases of rehabilitation. Phase 1 in that acute stage, look at the Rice principle. Progress to the next phase is guided by the initial response to treatment. Work on deficits identified in associated regions, around the back, around the arms, around the calves. In the phase 2, subacute phase, early range of motion in protective exercises and passive stretching. Note, Aisling strongly suggests that you don't stretch them passively, but allow them or someone else, and don't allow, them or anybody else to stretch them, but use active movement instead, and we'll look at that in a moment. Initially look at multiple joint angle and submaximal isometric contractions, looking at that trunk stability being very important. Isotonics, and then commence on with introduction of resisted work. And swimming and upper body workouts to encourage general cardiovascular conditioning is important. Looking at early passive and active range of motion, and this is more what Aisling is suggesting that's being done, rather than somebody passively stretching them, but do it with active movement. And really then, is it stretching or is it dynamic movement control? If you moved in and out of these positions as opposed to statically holding them. And that in and out position into these movements may then be more of a factor of muscle length through varying ranges with torso control. That may be what's the effective measurement here. Using tools for exercise to allow you to do this if you don't have enough of that torso control and limb control, using the different devices to get range of motion and support the core. And then looking at it with torso movement. The bottom photo is raising the legs up and down, so hip flexion and extension as the ball is being squeezed. Then we can look at isotonic adductors and adductors against gravity, introduction of resistance work or a partner. Here it's done with a tubing, really looking at that torso alignment. Rehabilitation keys, identifying the functional biomechanical deficits in the kinetic chain that contribute to this repetitive microtrauma, may be related to past micro or macro trauma injuries. Restoration of functional kinetic chain, rather than specifically just on the injured tissue. Again, it may be related to past injuries, age, or experience in the sport. This would include looking at posture, static and dynamic postures, articular and muscular regions, and its involvement in posture, both static and dynamic. Such a thing would be Trendelenburg sign. Looking normally that the lifted leg pelvis has a slight rise, and commonly what you see is the abnormal picture here with a weak gluteus medius. You can look at Faber's or Patrick's test, which is looking at in this case, the left knee, and looking at the distance of the lateral aspect of that left knee to the supporting surface, like a plinth, when the heel is placed on the opposite leg. And you're looking at the affected side staying elevated in flexion, adduction, external rotation, and extension, indicating that there may be some sort of functional length issue here to be dealt with. You can look at the hamstrings associated length regions. A functional way to do this is just look at the back of the knee to the back of the table. And again, in both the previous Patrick's test and in this particular test, it may not be the hamstrings or the groin in the Patrick's test that's what's decreasing these functional length tests. It may be other muscles that are changing movement around that hip and its associated two joint structures. To look at dynamic hamstring length in sitting or in lying, looking at the ability to actively extend that out, and I like to look at also what is the core doing as you do this. There's, I've seen debate about stretching out there. You can look at the stretches. I highly advocate, whether we're doing groin stretches or hamstring stretches, is looking at these as dynamic, as well as looking at the core control or the torso, pelvis, spine, hip, knee, ankle control of movement as you're doing these. And once that torso, pelvis, hip control is lost, that's as far as you would go into this particular range. That's more what I'm concentrating on than the actual length of the hamstrings and looking at it as a hamstring stretch. Balance and posture. There's been loads of studies looking at the importance of balance and posture in prevention of ankle injuries, and I would not be surprised if we start seeing this showing up in other injuries and decreasing their reoccurrence. Again, because of the importance of the torso, pelvis, leg control and the synergistic action of all these joints and muscles in this area. As again, looking at proximal and distal treatment as needed, even if there is a hip function, looking at what the foot is doing and helping them maintain the appropriate foot control or whatever the proximal or distal treatment is. And looking at those core recruitment, range of motion exercises, a bit of control around the hip, etc. A variety of ways you can do this, such as and you can do other things. Looking at the core, there's more and more now people are looking at real-time ultrasound, looking at the ultrasound and looking at recruitment of transversus and looking at the pelvic floor, or getting some interpretation of whether or not those muscles can turn on and off. Doesn't let you know about the muscle's strength or its fatigability. Just gives you another kind of proprioceptive or biofeedback tool, I should say, instead for you, the therapist, to see are things working like as you'd like to. And the other therapist in this photo that's standing with the clipboard is Louise Vian, and that's me using the real-time ultrasound on a particular athlete. We've been experimenting now for over 4 years on using real-time ultrasound with athletes, high-level elite athletes, looking at more standardized positions that are reported in the literature, as well as looking at this functionally in other positions that haven't been validated in the literature. And we've both seen significant results in decrease of microtrauma injuries and increase in ability to train higher outputs in terms of what they can lift and speeds that they can do in their sport-specific training. So we're quite excited about its usage here. Let's go back to that again. On the left side is pre-training, and clicking on the study, we look at this athlete. She's done an active straight leg raise, and there's a lot of compression of her bladder, etc. In this. That's the big black blob in here. So a lot of indication that she's really bracing potentially through her abdominal area and not able to support it well enough with the rest of her core. Now when she does it post-training, there's much less compression of her bladder. She's able to synergistically recruit what appears everything through there, and what she also reports reported was that she had more ease with lifting up the leg. It popped off the ground, it felt way lighter, and it was hardly anything for her to lift the leg. And this occurred in, well, the time there on the screen is 2041 and 2054. So, you know, in less than 15 minutes we got this change. You can use isometric contractions of your adductors, coordinated hip joint related muscles and torso muscles with dynamic exercises. Doing it statically without torso movement, and then with torso movement, as the top two photos are doing, and then the bottom photos are doing. You can look at the top photos without torso movement with moving the leg up and down. The bottom photos are keeping the contraction and then moving the torso up and down. And there certainly have been studies that show that these are some good exercises that may help decrease groin and hamstring strain. Bent over row using the real-time ultrasound, as I had said earlier, we're starting to do other functional exercises to see if we can make a difference with these athletes and help them find these muscles to recruit. And it seems that we're getting somewhere with these. So certainly has to do work to show this proven in a study, but clinically over the last 4 years we're seeing that difference. And we've done this with cleans, and we look at videotaping them and then analyzing their movement and using that as a biofeedback tool for the athlete. We also do that with looking at them running, although I'm not following them with the real-time ultrasound. The third phase of rehabilitation is ongoing conditioning as needed for the cardiovascular and other areas, exercise bike, treadmills, looking at flexibility assessed dynamically in regular intervals and seeing what's happening, using other interventions such as gun IMS, dry needling, massage therapy, ART, etc. as needed, manual therapy as needed, isokinetic exercises for areas around, and progression of earlier work as stated, using on the adductors, hamstrings, bridges, deadlift, tubing, eccentric, concentric work, etc. And rehabilitation key points to think about: core stability and agility, coordination, and I just can't say that enough. Coordination, coordination, coordination. We could replace AB and adductors here with the hamstrings and the quadriceps here. More advanced exercises in supine, on the ball, Pilates mat work, other creative things with the real-time ultrasound work. Activating the gluteals and hamstrings more for both groin strain injuries and hamstrings injuries in a variety of different hip ranges of motion. Looking at gluteal activity, David Lindsay has showed a few of these exercises have been good in recruiting the glutes and decreasing anterior hip flexor or hip issues, and I've been using them for groin and hamstrings injuries, and they seem to be working again exceptionally well, using them on the thought process of coordination of the synergistic muscles around that hip area. Activate the entire functional kinetic chain of muscles and joints. Exercises that integrate foot and hip function in positions that simulate running is important, such as lunges, bridges, balance reaches, side steps, crossover runs, ladder runs, etc. Box jumps up and down. Simultaneously using the abdominals, multifidus, pelvic floor, gluteals, hamstrings, the adductors, the whole thing. These are just a few of the examples that you could use. You can advance these exercises looking at eccentric range of motion and dynamic proprioceptive exercises, stimulating the concentric and eccentric strengths, maintaining core stability, including the torso and lower extremity in these exercises. You can be very creative doing this. You can advance these exercises using slide boards or other devices. You can use the Nordic hamstring stretch that has been shown as an exercise, an eccentric exercise, for decreasing hamstrings strain reoccurrence. And similar type of idea you can use for the adductors with tubing or other resisted activities, doing an eccentric load. And here's a variety of ways you can progress that, looking at the hamstrings and hip musculature with medicine balls or with different levers or with different weights. Phase 4, once they show isokinetic exercises comfortably, looking at running programs, straight line running first, back and forth program, backwards jogging to emphasize hamstrings and gluteal strength and control, hill and stair program, starting at various starts at various and varying distances, speeds, different terrains, acceleration, different explosiveness, adding various leg joint positions, i.e. doing ABCs with running, hops, jumps, etc. with the running. All those things lead to sport-specific drills. In this particular case, this would be a sport-specific drill for speed skating, and creating those, keeping these exercise principles in mind. Gradually working up to more rapid acceleration and deceleration drills for eccentric work of the gluteals and hams, and different drills for this. Running drills that I just mentioned, and that you could advance more. Cutting and pivoting drills and shuttle runs. Training intensity gradually increases, and starts the agility work and sprinting work in various starting positions. Jumping, cutting, running. You could start looking at advanced stretch positions. Some of you might think of these as yoga positions, and looking at ballistic movement or dynamic movement in and out of these positions. And not every sport is the same. Groin and strains, hamstring strains in speed skating, hockey, soccer, cross-country skiing, or even the industry stem from extremely different mechanisms. Thus, it must be assessed and rehabilitated in the context of specific demands and planes of motion of the activity. So that final phase is looking at the return to sport. And there's no consensus in the literature when the athlete can return to sport. So use every effort to mimic sport-specific training activities done in pain-free ranges, normal strength they must have back, full agility, no focal tenderness. Then most people agree that full activity is allowed. The goal is to minimize re-injury. That's the biggest thing here. And focus should therefore be on maintaining a flexibility around that area and associated areas, but especially strength, concentric and eccentric strength and strength ratio. So the keys to rehabilitation for groin and hamstrings injuries is establish an acute and accurate diagnosis, identify the biomechanical deficits in the chain that might be contributing to microtrauma, restore the functional chain rather than just focusing on the specific injured tissue, and eccentrics, core stability, and agility. Important. And I wish to say thank you to the University of Calgary Kinesiology Department, the Sport Medicine Centre, Sport Physiotherapy Canada, Marda Loop Sport Physiotherapy, and Speed Skating Canada, as well as Dr. Carolyn Emery and Dr. Tom Best for assisting me in my past research in this area. I hope you enjoyed the lecture, and if you need to contact me, my email is matthew@ucalgary.ca if you have any questions concerning this lecture. Thank you.